Hello, and welcome to today's 3M Health Information Systems webinar. My name is Ryan.
And my name is Jared.
And we'll be your hosts for today's webinar. We're excited to have so many of you joining us for our first CDI Innovation Series webinar. Many of you are already familiar with our quality series, and that really dives into key elements of different quality issues. And if you're not familiar with that series, you can visit www.3m.com/HIS/quality. Again, that's www.3m.com/HIS/quality. But we're excited to be kicking off this new series with you all. Really, there's never been a more exciting or challenging time to work in CDI, with changing payment models, shifting sites of care, the rise of healthcare consumerism, and so many other trends. Really, we're seeing a push for CDI to do more and go further. And here at 3M, we're excited to be empowering that advancement of CDI, and this series really is intended to do just that. There's 3M and industry experts that will be sharing their insights on some of the most pressing issues in the industry. And we hope that you'll find tremendous value throughout this series. We'll be having it every other month and hope to have hope to have all of you joining on a regular basis. But without further ado, let's jump into today's webinar. In today's webinar, we're going to be reviewing the components of a successful CDI program in the emergency department.
We encourage you to ask questions throughout the presentation. You can do this by using the questions feature in the web meeting controls, which is located in the lower right portion of your screen. We are recording today's presentation, and a webinar archive will be available, so look out for an email within the next week that includes a link to the archive. A PDF that contains all the presentation slides is available for you to download, and that's located in the handout section of your web meeting controls. We'll also provide a certificate of attendance to webinar attendees, and that will be emailed to you upon the completion of this webinar.
Thanks, Jared. And today's presenter is Bobbie Starkey. Bobbie is an outpatient expert and consultant here at 3M Health Information Systems. And Bobbie, again, without further ado, I know everybody's excited to hear what you've got to present, so we'll turn the time over to you.
Thank you so much, Jared and Ryan. I appreciate that. And thank you all for joining us today for a discussion regarding what we're looking at as kind of a precursor to a CDI program in the emergency department. You could also kind of look at it as a housekeeping task for your revenue cycle. We think this is a very pertinent topic for a couple of reasons. First of all, quality, accuracy, and revenue are very important elements of any patient care setting. We always want to make sure that we have documentation to accurately reflect our patient care and outcomes, as well as to support the revenue that we're reporting. Secondly, as more and more facilities are starting CDI programs in their ambulatory areas, we want to make sure that you have a good foundation for your ED CDI program. CDI in your emergency department is going to be very different than the traditional inpatient CDI programs that we're so familiar with. Nursing documentation is going to play a critical role in the ED coding and charging, which is not the case with inpatient CDI. The facility E&M levels and drug administration coding are going to be based on nursing documentation, and this is a concept not even considered in the world of inpatient CDI. So today I'm going to spend our time together painting a broad picture of some of the components of the ED revenue cycle that you may want to look at in detail if either you have started or are planning on starting a CDI program in your ED. So a few of the things that we're going to talk about. We will do a real quick ED revenue cycle overview. We'll look at 4 of the major components of the ED revenue cycle, certainly not all of them, but documentation, charging, coding, and denials. And then we'll talk a little bit about how can we ensure accuracy in these areas. We'll spend a majority of our time today talking about common ED errors, and it's not common ED coding errors, and it's not common ED documentation errors. It's a little bit of both. And then we'll summarize what we've talked about, and hopefully we'll have time to answer some of your questions. So why is revenue cycle accuracy so important? And one of the main reasons is patient care. We need to make sure that we're supporting medical necessity and the acuity of our patients. Our job as coders is to tell the story about how sick the patient is using our codes. Continuation of care, especially in the emergency department, it's a place where a lot of people will come and then get transferred to either another facility for an inpatient stay or up to the floor in our facility where our ED is located, or they follow up. If they're discharged home, they may follow up with a specialist. So that continuity of care is very important and basically starts with that ED note. Impacts to ED resources is not really something that you think about when you think about patient care, but if you are getting the revenue that you're entitled to, you have your documentation and your coding and you're supporting that revenue, you may be able to hire more nurses. You may be able to hire or to purchase more state-of-the-art equipment. If that's the case, then in turn, you're going to be able to provide better patient care. Payment responsibility is another area that you don't necessarily think about when you think about patient care. But if you are documenting and reporting the coding as it should be, you're going to support medical necessity for tests, which otherwise would have to be paid instead of by insurance by the patient. And that really isn't good patient care. Another area that revenue cycle accuracy is important is compliance. And we've had it beat into our heads about fraud and abuse, but also our medical records are legal documents. So if you have a record that's getting subpoenaed for a court case, you certainly don't want that to be the place where an inconsistency in your revenue cycle comes to light. And then revenue, of course, we want to make sure we're getting accurate and timely reimbursement, and we want to do it without a lot of denials and a lot of rework. So that's why the revenue portion is important. And then data integrity. And we all know that our data isn't being used just to pay for claims anymore. It's now used for statistics. It's used for benchmarking. Everyone is using our data, research, registries, trending, RAF scores and HCC reporting, our hospital outpatient quality reporting programs and MIPS programs. It's used to create patient treatment plans and protocols, as well as predicting future patient populations. So our data is really being spread out there, and that's why the CDI programs are so important right now. So 4 of the major components of the ED revenue cycle, again, not all of them, but the ones that we're going to touch on today are documentation, and we'll talk a little bit about physician documentation, nursing documentation in the ED, and ancillary documentation. Charging, we won't talk a lot about ChargeMaster, but there are a few things that I want to make sure I mention. The main thing we'll talk about is who is responsible for that charge posting and how does that process work. And then coding, we have our diagnosis coding, our procedure coding, the E&M levels. And when I talk about E&M levels in this presentation, I'm talking about facility E&M levels and your drug administration coding. And then for denials, 2 of the major places that you'll have denials for your emergency department are going to be your medical necessity denials and your modifiers. So this brings us to our first polling question. Who is responsible for posting ED charges in your facility? Make sure that you select all that apply. We have nursing, HIM coding, an outside service, other folks, or you're not sure. And while Jared is calculating that, I just want to remind anybody who's thinking, well, I outsource my entire ED revenue cycle, so this doesn't pertain to me. These are still your claims. They are still your denials. You need to make sure you stay in this loop. Just because they're not in your facility doesn't mean you're still not responsible for that information. And then also I want to mention when you have multiple people, like if you have nursing posting charges and then HIM coders coding the claim, it makes it, the more people you have involved in that revenue cycle, the more difficult it is. And you need to make sure that you're consistent and you're keeping everyone in the loop when you're using different departments. So Jared,
Awesome.
Do we have?
Yes, we do. Gonna close it out and share. So we had 13% say nursing, 38% said HIM coding, 6% outside service, 14% other, 28% don't know. Okay,
and see, that is very much spread out. So just make sure when you have different areas doing this that they all have the same information and they're working together. So moving on to documentation, We have our physician documentation, which is going to include our emergency department note, any consults that are done, procedure notes. We know we have to have a procedure note from the physician for any procedures that are done, and then orders. Nurses can't perform functions without an order from the physician, so those orders are very important. When we talk about other documentation, we have our nursing notes. Like I said earlier, in the emergency department, nursing notes are very important to the revenue cycle. We also have our ancillary documentation, which could be respiratory therapy, interventional radiology may perform a procedure or document in the chart, and then your drug administration documentation. Looking at physician documentation, we need to make sure that our physician documentation is complete and specific. So one way that we can help make the physician documentation complete is we need to make sure that we have, of course, a final impression. This also is something that we need to watch for. If you have a patient who comes in and the physician on duty at the time orders some tests and starts the workup on the patient, and then shift ends and they're going to leave, and another physician takes over care of that patient, even if that physician discharges the patient and doesn't do anything else, he still needs to put a note in the ED note stating that the patient was stable, tests came back negative, and he discharged the patient and where they were discharged to. So you need to make sure that those notes are completed. Make sure that any procedures that are done are documented. Any chronic conditions, pertinent history, and current medications are documented. And we're learning more as we're getting into the HCCs that those chronic conditions, it's very important that they're documented by the ED provider and that they're documented to the greatest level of specificity. A lot of patients, the only visit they may have that year with a face-to-face with a physician is going to be in an emergency room. So we need to make sure that that information is getting picked up. Current medications also have some of the current medication codes, the long-term use of medication codes, meet medical necessity for certain tests. So we want to make sure that those are also documented. And then specific. There are ways that we can make our physician documentation specific, and one of them is preference lists. And if you have electronic EHRs, you may be familiar with preference lists. One of the things that I want to point out here is someone in the department, in the emergency department or NHIM, needs to make sure that they're reviewing those preference lists to make sure that they're appropriate, at least annually. New codes come out, diagnosis codes change. You want to make sure that they're up to date. And another thing I want to point out in regards to that is if there are diagnoses on those preference lists that are very ambiguous, and an example I'm going to use is kidney disease or renal disease. It does not say acute or chronic. It does not give you a stage. It just says kidney disease. That codes to a disease of the kidney. It does not code to chronic kidney disease. It does not allow you to report a stage. For HCCs, those are going to be important items. So just look at the preference list and make sure, or you don't want to remove them or tell the doctor not to use them, but educate the physicians that if you're going to have this diagnosis, if you're going to use this diagnosis, you should only be using it when you don't truly know if it's chronic or acute or the stage. And then another way is queries. Make sure that your queries are appropriate. A lot of you probably already have query processes for your ED physicians. Make sure that you trend those queries and provide education based on those trends. If you have a physician that's constantly needing to be queried, educate that physician. If you have either a diagnosis or a procedure that's constantly needing to be queried, provide education on that as well. And then templates, we can use our templates for our procedures sometimes to help the physicians be more specific. Another thing is if you have ambiguous information that's constantly causing grief for your coders. So the physician, a good example is he says that he repaired a wound, single repair, and it was an intermediate procedure repair. But he doesn't have any information there that supports that intermediate repair. Take that field of the template out that says what type of repair it is, because if he's not going to support it, you can't code it anyway. And then moving on to nursing documentation. So as I had said earlier, nursing documentation is crucial to the ED revenue cycle. Your facility E&Ms, or visit levels as they're called, including critical care, are based on your nursing documentation. Regardless of the amount it's based on, nursing documentation will depend on the tool that you're using. But every tool uses some extent of nursing documentation in order to assign those accurate facility E&M levels. Drug administration, your start and stop times, as well as the routes that the drugs are administered, are necessary to be able to assign an appropriate drug administration code. So you want to make sure that those are being documented. You're present on admission and injury information. And when I say injury information, I'm talking about your external cause codes, how the injury occurred, where it occurred, those and the activity. Those can be based on nursing documentation, not the actual assignment of the fracture or the wound, but the external cause codes. And then you also have your ancillary documentation, which, as I mentioned before, could be respiratory therapy. They may insert an ET tube, or cardiology may come in and perform a cardioversion. Interventional radiology will do a jejunostomy tube replacement. So other areas can also be documenting in your record. Moving on to charging. Again, I'm not going to get into the charge master too much. There's a team that is responsible for maintaining the charge master. Your department, so there should be someone in the emergency department that's responsible for, when the code changes come out, reviewing the new CPT codes in January, reviewing the charge master and their electronic or paper charge tickets to make sure that the new codes are added, the deleted codes are removed, any code revisions are updated, and make sure that there is a one-for-one match. Every CDM number, every charge description, the CPT code, everything matches 100% between your CDM and your charge ticket that you're using. As you can see in our example here, the CDM has, the CPT code doesn't have, I'm sorry, the CDM is on the bottom. I'm getting confused. The CDM is on the bottom. It has the CPT code 10061. The box on the top is the actual charge ticket example. There is no 10061 code on the charge ticket. So if you're outsourcing your charging and coding for ED, and this coder gets a case where she needs to report 10061, what is her course of action in that case? If she doesn't know what to do, she may just assign 10060 because it's the next closest thing. She may not report anything at all. You need to make sure that you have policies in place for what needs to be done when a coder or your charge staff come across a procedure that they don't have any way to bill for. Someone should review it and make sure it's the appropriate procedure code, and then follow the process of having it added to the CDM, added to the charge ticket, and then letting the staff that actually are going to report those charges know it's there, this is when it's used. So it's important, again, that you keep that loop, keep everyone in the loop on how to get charges added to the charge master, and then make sure that they get the follow-up as far as it's there, now you can report your charge. Another note on the charge master before I move into coding. Make sure that like your coders need to be, or whoever's posting charges need to be able to see if respiratory therapy charged for the ET tube insertion, or if cardiology charged for the CPR. They need to know that that department charged for that service. Now, I don't need to do it. So you want to make sure that you're not duplicating the charge process. And on that same token, you want to make sure that every procedure or service is getting charged. So an example of that is we had a facility that had a PIC team that would float around the hospital as needed and insert PIC lines. And they would come to the ED and insert PICs when it was needed. They weren't posting any charges for that service. The ED didn't have any way to post a charge for that service, so no one was posting the charges for the service. You need to make sure that all the services are getting charged once, and they're only getting charged once. So moving on to coding. We have our diagnosis coding, which is going to be our ICD-10-CM, and that includes our external cause codes. We have our procedural coding, which is going to include our CPT. Our drug administration is part of our CPT, and that includes both IV and IM infusions and injections. And then our facility E&M level is also going to be part of CPT coding, and that is going to be any nursing interventions and ED resources that don't have their own procedure code. So if it doesn't have a procedure code, it can be included in nursing interventions. And a couple of examples of that are going to be providing an enema for a patient, placing a bear hugger. Those types of things are things that don't have CPT codes that the nurses perform and utilize as resources that you want to include in your facility E&M. And then another type of procedural code is your HCPCS codes. And in the emergency department, those are typically going to be drugs, but your Dermabond supply, the glue that they use to close wounds, that is a HCPCS code. Moving on to denials. So we recommend, and that's why there's a star there, that HIM staff work denials. There are going to be some denials that are going to be age denials or birth date denials, gender denials. Those, anybody could work those. The reason we think that HIM staff should be the front line for working the other denials is, one, it takes the same skills to work those denials as it does to code the account in the first place. So the same guidelines have to be followed, the same rules, the same documentation. The billing staff, in all fairness to the billing staff, they're not going to be able to go look at that record when they're working the denial. You almost have to look at the record when you're working the denials. So our recommendation is to have HIM staff work your denials. Their typical denials are going to be medical necessity in the ED. And some of that is your physicians not documenting to support the medical necessity. Some of it is the coders not finding the documentation to code and support the medical necessity. And we'll look at that a little bit further when we look at the ED errors. And then your modifiers. You may choose to have your modifiers assigned by your coders when they're coding the case. And they may modify all, clear all of the CCI edits. Keep in mind, if you have them do it on the front end, you may still have process on the back end that needs to be done because you're going to have accounts that have late charges posted, or you're going to have claims that are combined on the back end. So even if you want it in the front, you may still have to perform some of those functions on the back end. On the back end would be you let them go through and the claim scrubber pulls them out and someone just works those claims. So how can we ensure accuracy? We want to provide guidance for our coding and charging staff. So again, if they find a procedure that they've never done before, something new, they don't have a charge for it, what is their course of action? Make sure that they know that. Education, we want to make sure that not only our coders are being educated, but our physicians. If you, again, trend your queries, you're going to be able to provide them with feedback. In this case, for the ED, you may also want to educate your nursing staff. They may have queries. Your drug administration code documentation, if it's lax, make sure that you're educating those nurses on how they should be documenting so that you can bill those cases appropriately. Your coders, we recommend quarterly meetings with your coders just to talk over something new or something that they're struggling with. And one thing, if you can get physicians and coders in the same room for even a half an hour once a year to talk about some procedure that they're doing, or have the coders ask questions ahead of time on something they'd like to understand better that the physicians are doing, the coders love it when they can hear from the physicians. And then the final thing is audits, and I can't stress this enough. You want to make sure that you're doing internal audits. You want to make sure that you're doing external audits, because sometimes you don't know what you don't know. You may have, the guidelines changed last 6 months ago and you haven't had a chance to catch up on that. Someone from the outside with a fresh set of eyes may see something differently. And then make sure that you're auditing not just your coding, but also your documentation. Again, your nursing documentation in addition to your physician documentation. Make sure that you're auditing the charging and your denials. identifying those trends and providing that education. So now we're ready for polling question number 2. Who performs the coding of your ED records? Is it your hospital or internal coders, outsourced or external coders, a combination of both internal and external, or you're not sure? So the reason I'm asking this question, I want to make sure that you ask yourself, how often are you performing audits? And are you having both internal and external coders audited? Are you performing audits on both of those staff? And if you have outsourced coders, are you going to audit the staff, or does your vendor send you audit results on a regular basis, or do you not get any audit results for them at all? So something that you may want to think about and make sure that you understand the accuracy for those coders, whether they're yours or from the outside. And Jared, do we have responses?
Awesome, yes. I'm gonna close it out, share. Okay, we had 55% say hospital internal coders, 12% outsource external coders, 19% combination of internal external coders, and 14% I don't know.
Okay, so yeah, those of you that have external coders, make sure that either if you're not getting it from the vendor, that you're doing some auditing of those coders as well. Again, out of sight, out of mind doesn't fit here. You still are responsible for the accuracy of the codes that they're reporting and those claims going out the door. Okay, so now we're going to move into some common ED diagnosis errors. And we talked a little bit about medical necessity. Our coding guidelines for outpatient tell us that we are to code all documented conditions that coexist at the time of the encounter or visit and require or affect patient care, treatment, or management. We're not going to code conditions that were previously treated and no longer exist, but we can use history codes as secondary codes if that condition or history has an impact on the current care or influences current treatment. And I'm sure that some of you have probably seen the MEET acronym. We say if it meets MEET, then it can be coded, and MEET stands for monitored, evaluated, assessed, or treated. And it basically reiterates what our coding guidelines tell us. It requires or affects patient care, treatment, or management. So an example on the right-hand side, this patient came in and had a final diagnosis of a closed torus fracture of the distal end of the right radius, initial encounter. And in the physical exam of the ED note, he notes in red there, right elbow. She exhibits normal range of motion, no swelling, effusion, no deformity, and no laceration. Tenderness found and radial head pain noted. So the patient has a final diagnosis of a fracture of the distal end of the right radius, which is the wrist. In the physical exam, he's talking about the right elbow pain. The portion that's circled in green is the findings from the x-ray of the right elbow. It says there's no evidence of fracture. So we have a patient who really has a wrist fracture. It's supported in the diagnosis, and as you can see in the physical exam there in black, it says right wrist. She's got decreased range of motion, tenderness, and bone tenderness. So this patient has a wrist fracture, but he's also done an x-ray for that radial head or elbow pain of the right side. So this patient's correct coding would be the torus fracture of the lower end of the right radius, initial encounter for closed fracture, but also pain in the right elbow. That pain in the right elbow meets medical necessity for the x-ray done of the right elbow. They would not have done an x-ray of the right elbow for wrist pain. So if it was wrist pain documented, you wouldn't, because that's integral to the fracture, but we have elbow pain in addition to the wrist. A couple more medical necessity examples. The one on the left, the clinical impression is vomiting and diarrhea and dehydration. But in the doctor's note, within that note, he has this little tiny summary paragraph, and they're really good about putting this paragraph in their ED note. Sometimes they call it an MDM note, medical decision-making note. Sometimes they call it ED course or clinical course, and sometimes they just call it note. But this particular note says, now patient does not want to be hospitalized. discussed with patient and convinced her to stay in the ED for further observation due to tachycardia. So sometimes tachycardia is a symptom of dehydration, but in this particular case, this patient's convinced to stay in the ED for further observation due to the tachycardia, not the dehydration, but the tachycardia. Our coding guidelines tell us if it's an extended stay, if that condition extends the patient's stay or requires additional treatment, it needs to be coded. So in this case, I would code additionally the tachycardia. On the right-hand side, we have the clinical impression, mild persistent asthma with acute exacerbation, acute cystitis without hematuria. And then in that same little perfect little note that summarizes what's going on, the physician says, we'll give the patient prednisone for wheezing. He just had a full cardiac eval. We're going to give him Lovenox for a low INR. And then Dr. ABC is going to follow up and adjust his Coumadin dosing. He was asked to return at once if worse. So this patient had the prednisone for the asthma exacerbation, but there's no reason for giving him the Lovenox other than the abnormal PT-INR. The patient had a low INR. In this case, that abnormal finding can be coded because it was treated with Lovenox on this visit. So, and you can decide as a facility, do you want the physician to be queried to add these to their clinical impression, or is this documentation enough to assign the codes? It is enough to assign the codes, it's just a facility decision in this case. Another thing is fracture specificity. In ICD-10, our fracture codes are crazy. We often get, and I think it's due in part to how our EHRs are set up, but we often get from the ED physician a generic unspecified fracture code. And it really, if you read this, unspecified fracture of the lower end of left radius, initial encounter for closed fracture, it sounds like, wow, that's a lot. He gave us a lot of information. But if you look at the x-ray report, a lot of times you will see this second example, it was actually a Salter-Harris type 2 physial fracture. Or the third example, it was an interarticular fracture of the lower end of the left radius. So that could be way more specific. And using the x-ray report for the specificity is allowed because the radiologist is an MD. The only time you would want to question or query the physician, the attending physician, is if they conflict. So if the radiologist says there's a fracture and the ED physician says no fracture, or vice versa, in that case, you want to write a query. But just to get more specificity regarding something that the physician already diagnosed can be done using the x-ray report. So you want to make sure that you're getting that additional information. Here's an example. This patient had a CT scan of the left ankle. The final impression says acute minimally displaced lateral and posterior malleolar fractures. The final diagnosis provided from your ED physician was closed fracture dislocation of left ankle initial encounter. So the initial code assignment that the coder coded was the other fracture of left lower leg, but what should have been coded was a displaced bimalleolar fracture of the left lower leg. Another thing in ICD-10 that's changed a bit is the coding of crush injuries. So crush injuries in ICD-10 are coded with 2 codes plus your external cause code. If you look at category S67 on the left, this is actually how you would code a crush injury of a hand or wrist or finger. But in this case, I'm using the example of hand. If the physician says the patient has a crush injury with a laceration or a crush injury with a fracture, then you're going to report a category S67 code first, and then per the use additional code notes here, you would also code the fracture or the open wound as appropriate. So it's going to take 2 codes to report those crushing injuries. And your S67, your crush injury code, is always going to be your primary code in this case. Same thing with muscle and tendon injuries. So in the ED, if the physician says the patient had a laceration of their hand and it extended into the muscle, you're going to code a category S66 code first, And then you're also going to code the open wound code of the skin S61 category as an additional code. So those lacerations into tendons or muscles, if the fascia, tendon, or muscle is involved, then you have to code 2 codes, the S66 if it's the hand, and then your additional open wound code. Keep in mind, just because it's lacerated and the wound is repaired doesn't mean the muscle or tendon is repaired. A lot of times the ED physicians will suture the skin and then send them to a specialist to have the muscle or the tendon repaired. If they do repair the muscle in the ED, that's going to code to a complex wound repair. If they code a tendon, it's going to actually have its own musculoskeletal system code. In this case, it would be a 26410 for the hand. And the extensor tendon, because the flexor would be different. And then underdosing. So underdosing is still being underreported. It seems that the coders want to see underdosing documented, and the physician's not going to say the patient's underdosing. What they're going to say is the patient hasn't taken their meds for 5 days, or they never got their prescription refilled. And the definition of underdosing in our coding guidelines says, underdosing refers to taking less of a medication than is prescribed by a provider or manufacturer's instructions. So you want to make sure if you see that the patient's not taking their meds like they're supposed to be, you're going to report the underdosing code. You would also report the Z code for noncompliance if you know the intent of the noncompliance. So did they do it on purpose, or was it something out of their control? And then there's your reference from official coding guidelines. And this is an example. We had a patient who had a history of hypertension. She came in, she's had a headache for a few days. Her headache is worse, not relieved with over-the-counter meds. She's got high blood pressure, and it's 192/84 in the emergency department. She stopped taking her blood pressure medication a couple months ago, trying to see if diet and exercise would help with her BP. States it was well controlled while on the medication, but has slowly been creeping up since she stopped. Her clinical impression here is essential hypertension. So she's here for the condition that those meds that she's not taking were prescribed to control. And that's typically what you'll see. And then your correct coding, I have a correction here. Your first primary code would be the I-10 for the essential hypertension. And then after that, you would code as a secondary the underdosing of antihypertensive drugs initial encounter. And then we know that she's intentionally underdosing because she chose to stop to see if she could control it with her diet. So we would add the Z code for intentional underdosing of medication regimen for other reasons. So just make a note there that the essential hypertension should be coded first because your T code is not going to be primary. It's going to be whatever condition is going to be your primary diagnosis. Now moving on to common ED procedure errors. The first one we're going to look at is anicoplasty. Hopefully I'm saying that correctly. This procedure note on the left looks like a simple wound repair when you look at it. But when you get to the comment portion of the procedure note, it says that the nail was removed. There's a laceration across the nail bed. It was sutured with Vicryl. The nail was then replaced in the sulcus and sutured with ethylene. So the nail was taken off, the nail bed was repaired, and the nail was replaced. And we have a CPT assistant, December 2002, that says specifically this is the definition of an anicoplasty. So the initial code that the coder coded here was 12001, but indeed it was a 11760. And the repair of nail bed is going to require anatomical modifier, so either fingers or toes, where the simple repair code would not because that's your skin. Cerebral TPA is another area that coders frequently miss or miscode. A lot of times they will code this with a drug administration infusion code. And if TPA is given peripherally, that is the correct way to code it. But your coders need to watch if the clinical impression is ischemic stroke or it's given as therapy for an acute ischemic stroke. you want to code 37195 for that cerebral thrombolysis. And the difference in reimbursement here, reimbursement for the 37195 is $288.38 based on the 2019 fee schedule, versus if you report the Drug Administration infusion code, that's $187.18. So there's $100 difference in coding here. So just make sure if the patient's here for an ischemic stroke and cerebral TPA is documented, you want to make sure they're using 37195. Now, if you're not sure, and this is going to be the same case for all of these procedure errors that we're going to talk about today, if you're not sure if your coders are reporting these correctly, one way to check quickly is to look at your CDM and see, one, is the CPT code in your CDM? If it's not, they're not reporting it. Two, check your charge ticket. Is it on your charge ticket? If it's not, they have no way to report it. If it's in both of those places, you can use your CDM to run a frequency report on this CPT code or the CDM number. And you'll see how many times it's been reported, and you'll be able to tell by that. If it's not been reported at all, we have an issue. If it's just reported 1 or 2 times, I think it would depend on how large your ED is. But definitely the angioplasty is something that you see frequently. Cerebral TPA, maybe not so much. But just do that, and you can quickly see how those are being reported or if they're being reported. Continuous bladder irrigation is another area you want to make sure. The reason this one I think is being missed so often, one is you may have new coders that don't realize this is even a procedure. Two is they typically document this as CBI. They'll tell you they've placed a catheter, and then they'll say CBI initiated. If you don't know what CBI is, you're not going to code it. And this particular procedure reimbursement is $231.42 for the 51700. If you report just the catheter, which sometimes happens, 51702, that reimbursement is $106.48. So you're looking at about $120 difference here. And then the next one is interosseous line placement. This is, a lot of times EMS will place the interosseous lines before the patient arrives in the emergency department, but physicians do place them. This can be missed, again, new coder may not know it's a procedure, and they're documented as sometimes I with a /O line. If you look at ED records, you'll know that I/O also means input/output. So if you're not paying attention to what you're looking at, you may not realize that they're performing a procedure there. Another reason I bring this procedure code up is that if the physician places, or even if EMS places that interosseous line and meds are given via that line, you cannot report the administration of those medications. There's no code to report intraosseous infusions. It's either IV or IM sub-Q. There is no interosseous infusion code. So make sure that your coders know if those lines are being placed, you cannot report those drug administrations. And the reimbursement for an interosseous line is $348.16. So if they're missing that, it's quite a chunk of revenue. Ventilation. When we talked earlier about your coders or your charge folks being able to see what other departments are charging, this becomes very important for the ventilation coding. Respiratory therapy typically will put the patient on the ventilator after the physician orders it. And at that time, they're going to post the charge for 94002 because they don't know at that time if that patient's going to expire in the ER, if they're going to get to go home, if they're going to get admitted to your facility, or if they're going to get transferred to another facility. They have no way of knowing at that time. So they're going to post that charge. CPT guidance tells us, if you look at the codes 94002 through 94004, below that it says that those services cannot be reported with E&M services in the range of 99201 through 99499, which includes all of our facility E&M codes for the ED. So if your coder's coding and they have edits that pop up, and one of them is this 94002, they cannot put a 59 modifier on it. That code has to be credited. So whether the coders have the ability to credit it or it has to go back to the department to credit it, somehow that 94002 has to be removed from that claim. So you want to make sure that you have a process for that in place. And then we have critical care. This is one of my pet peeves. Critical care is a minimum of 30 minutes required before you can report the service. And a lot of times, coders will start calculating the time and try to calculate the time when they could just look at the time the critical care started and the time the patient was discharged or expired. And if it's less than 30 minutes, then you're done. You assign it to one of your levels based on your internal E&M guidelines, and you're done. You don't have to take all the time to calculate all those minutes. So just note that if it's less than 30 minutes, you have to report it with a level consistent with your internal guidelines. If it's more than 30 minutes, you have to make sure that your documentation supports that that patient did not leave the department where someone else was caring for the patient other than someone from the ED. So if the ED nurse goes with the patient, you can count that in your critical care time. If she doesn't, or if the nurse doesn't go, then you have to deduct that from your total critical care time. And this chart is actually from your CPT book, but it's a real nice chart as far as calculating your codes for critical care. And then the last thing I wanted to talk about was procedures included in E&M services. We have a lot of procedures. Well, there's three that I can come up with quickly here for you. One of them is wounds repaired with steri-strips. And CPT guidance tells us that if a wound is repaired, the sole material is steri-strip, you have no CPT code to code it, you're going to include it in your E&M level. If they use sutures and repair it, and then they cover the sutures with steri-strips, you're going to code the suture repair. But in this particular example, they closed the skin with steri-strips. There was no additional materials used to close the wound. This needs to be included in your E&M service. So you need to make sure in your E&M tool, you have a way to capture this. Otherwise, you're losing revenue. You're leaving it on the table. Another one is foreign body removals from the skin without an incision or a closure. And you got to be careful. Your coders sometimes will code these as with incisions when indeed there weren't any incisions made. So you have a coding clinic here that tells us to code the E&M service instead of 10120 in this case where the patient had a foreign body in their foot and it was removed with simple forceps, not an incision and not a closure after they removed it. So this has to be added to your E&M service. And this is an example of one of those templates that drive you crazy. Complexity, complex. Tendon involvement, complex. So they're barking complex all over the place, but this isn't any complex procedure. And then on the right, manual hernia reductions. You have a CPT assistant there again that tells you it's not reported with a procedure. You have to include it in your E&M. In this particular case, surgery was consulted and came to the bedside to do the manual reduction. So if you don't include that in your E&M service, you're leaving money on the table there. And then just to summarize, so our takeaways for today. Create policies where needed and make sure you distribute them to all impacted. So again, if you have an outsourced service that runs your whole revenue cycle for the ED, make sure they know these things. Distribute to your charging staff if they're different than your coding staff. Ensure that there's a procedure for adding, updated, and deleting charges in place and that someone is reviewing your CDM and your charge ticket to make sure they match always. Facility E&M guidelines include those procedures that per coding guidance need to be accounted for. And then again, I can't stress auditing enough. Perform internal and external audits, both coding and then other aspects of the ED revenue cycle. Your documentation, your charging, your denials, and identify opportunities for improvement, and then use those results to create education both pertinent and productive for your coding professionals, your nurses, your physicians, and any other key stakeholders. And use different methods to identify cases for audit. So don't just audit cases that have a surgical CPT code. As we can see from the errors that we looked at, especially if you have a lot of new coders, they may not know those are procedures. They're not going to code a procedure. Those cases are going out the door without an audit. Sometimes it's better to look at certain diagnosis codes to catch some of those things. And then HIM coding professionals should be involved in an initial review of the ED denial. So again, the ones that are gender or authorization, not those, but your coding denials and your charging denials and your modifier denials, make sure that HIM coding professionals are looking at those. And there are your references. And I think, Jared, Ryan, that's it.
Awesome. Okay. Yeah, let's move into the Q&A portion of our webinar. So if you'd like to submit a question, you can use the questions feature in your web meeting controls located in the lower right corner of your screen.
All right, and while you're submitting your questions, we wanted to let you know about a couple of different events. Bobbie, if you scroll forward one slide. We want to make sure that everybody's aware of our 3M Client Experience Summit. It'll be happening July 28th through the 30th at the beautiful Grand America Hotel here in Salt Lake City. This year's event will include a rich variety of educational sessions, networking opportunities, and thought-provoking keynote speakers. So make sure you mark your calendars for that 2020 event. Next slide, Bobbie. We're also excited to introduce this upcoming webinar. On February 13th, 3M Mobile Vice President Michael Finke and 3M Revenue Cycle VP Jared Sorensen will describe how 3M and M-Modal are using conversational AI and ambient intelligence to close the loop between clinical care and revenue integrity, reduce the administrative burden on clinicians, and transform the physician-patient relationship. So really a great opportunity to see how M-Modal now with 3M we're coming together to bring great new solutions and offerings for the market. So for those of you interested, there's a website there that you can register. Lastly, if you'd like more information about topics in this webinar, please select your area of interest. Jared will deploy that poll, and we will jump into the Q&A section. All right, so first off, Bobbie, the first question we've got looks like from Joseph. It says, how do you handle ED visits if the physician did not see the patient, but the nurse did the triage and patient left without treatment or without completing treatment before being seen by a physician?
Could you repeat the beginning of that? I'm sorry.
You bet. It says, how do you handle ED visits if the physician did not see the patient, but the nurse did the triage and patient left without treatment or without completing treatment before being seen by a physician? So basically, they saw a nurse, but didn't spend any time with the physician.
Yes, in those cases, you're going to be able to assign a diagnosis code, but there are if no procedures were performed, no services were performed, if the physician didn't see the patient yet, I'm guessing there weren't any orders for anything to be done, there's nothing that you can charge.
Thanks, Bobbie. The next one looks like from Daniel. It says, can a critical care code and a 99233 be coded during the same 24-hour period by the same provider?
That one I will have to look into and get back to you on.
Okay. Thanks, Daniel. Yeah, we'll be sure to look into this and send a response by email. Let's see. Next one. Sorry, scrolling through. Looks like on slide 14, wouldn't it be appropriate to also code the long-term use of Coumadin since its use was documented and addressed?
If it's documented by the physician in the medication list, yes, you would also code the Coumadin in that case. I don't know that I would have coded it just from that note. It says that they're going to adjust his Coumadin. It does not say that he's been taking it long term. But if it's documented in the med list and you can tell that the patient's been taking it, yes, then I would also code that long-term use of Coumadin.
Okay, thanks, Bobbie. It says, can a radiology report be used to code specificity for other conditions besides fracture? For example, the doctor lists a non-specific kidney stone diagnosis as a clinical impression, but the radiology report specifies it as a ureteral stone. Can or should we code the more specific location?
That, I think, would be a case where you need to query the physician. A lot of times if they say with or without hydronephrosis, so the physician won't document with or without hydronephrosis, but the x-ray report does say hydronephrosis, then I would code it with the hydronephrosis. But when you're talking about conflicting sites, I think in that case, the attending physician, either you're going to need to query or I would go with the attending physician.
Okay. Let's see. It says, does an x-ray report have to be included in the ER note in order to code from that report?
I guess I'm not understanding the question. Could you repeat it, please?
Sure. It says, does the x-ray report have to be included in the ER note in order to code from that report?
Oh, no. You can, if you have access to the radiology reports, the physician's using those reports to assign diagnosis. So yes, you can use the radiology report, whether it's included in the ED note or not.
Excellent. All right. It says, how are medications coded and billed if given intraosseously? If I'm saying that correctly.
Yes, interosseous medication administration cannot be coded. There's no way. The drug can be coded with your HCPCS code if there is one, but you cannot code the administration codes because none exist. There's no way to code that.
Okay. The next question is from Marla. It says, how should foreign body removal without incision done in the OR without anesthesia be reported?
In the operating room?
Yeah, it says without incision done in the operating room, without anesthesia be reported.
I guess I would need to know how are they, if it's without an incision, how are they removing that foreign body in the OR?
Okay. Yeah, Marla, if you've got a, oh, it says, so Marla clarified, she said in the OR with anesthesia.
Can you send that one to me via email? I'd like to look into that one a little further.
You bet. Marla will respond to that one by email. Let's see. Got several coming in, trying to keep up here. That one we've answered. Had some similar questions come in. So there's a follow-up from Joseph. It says, what if you follow advanced triage protocols and have orders and results completed? Do you charge? Don't you have to have an MD when you submit the bill?
That one I will have to also look into a little closer. If they've performed procedures, yeah, I'll have to investigate that.
You bet. Okay, from Jean, she says, I have coders that code specific injury codes when the ED clinical indication states trauma. Have you seen this?
I would need to know where they're getting the information to assign the specific injury codes. If it just says trauma, yeah, your physicians need to be a little clearer for one, but yeah, I need to know where are they getting the information to assign those injury codes.
You bet. All right, we've had a couple of those come in, but we are at the top of the hour, so those of you who we didn't get to will be sure to respond via email. Again, thanks everybody for participating in the poll.
Yep, and just as a reminder, we'll be sending out a link to the archive, so look for that in your inbox within the next week, and we'll also be sending you your certificate of attendance shortly after the webinar within an hour. So Bobbie, thank you for this excellent presentation, and thank all of you for joining us. This concludes today's 3M Health Information Systems webinar.